Welcome everybody on behalf of my IVF Answers with the European Fertility Society. So my name is Liadh Fitzgerald and you're in for an absolute treat today with the presentation that we have for you. So in a moment I'm going to introduce our wonderful presenter, but I just want to do a small little bit of housekeeping first, just to let you know that this is being recorded, okay? But it is anonymous, so nobody's faces or names are going to be recorded. If you have a question, please pop it into the questions box. If you put a question mark at the end of your question, it will directly jump into where I can see questions specific. If it's not a question, it'll go somewhere else and I will get to those as well. So sometimes if a question is very long, or if I might have problems reading it out, what I will do is I will share the question on screen. But again, it's completely anonymous and your name is not going to be shown, but your initials might. So this recording will also be available for you after the event, so you can go back and you can watch it again. But for now, I want to introduce to you the wonderful Dr. Mariliz Hatzipanteli. I hope I didn't do that too badly.
Very well.
Thank you. So from the wonderful New IVF clinic in Greece. So the Newlife IVF Clinic is very well known for a number of things. It does a huge range of investigations and treatments, but it's also known for its egg donation program. And the success rates of this clinic make it very much one of the top clinics for IVF abroad, so for patients traveling abroad. The topic that we're going to look at tonight is about ovarian reserve, and it is tailoring IVF for diminished ovarian reserve. So I'm going to pass you over to the wonderful doctor and then we will share the notes in a moment. So thank you very much.
So hello, my name is Mariliz Hatzipanteli. I'm a gynecologist and obstetrician, but I specialize in fertility. And as said, yes, I'm part of the team in Newlife IVF Greece. So we can, I think, proceed with the presentation. So today's talk is about low ovarian reserve and how we tailor IVF for diminished ovarian reserve. So a definition first, ovarian reserve is pretty much how many eggs we have in our ovaries compared to other women. Some genetic factors, we are born with approximately 1 to 2 million eggs, but by puberty, the number decreases to 300,000 to 400,000. And over the years until menopause, month by month, our reserve declines. How we assess the ovarian reserve? The most well-known marker is the AMH, the anti-Mullerian hormone. A scan to count the androgen follicle count, and FSH and estradiol levels are good markers as well. So when they are elevated, it's expected to become less and less. What can cause diminished ovarian reserve? Age, of course, chemotherapy for women that they have cancer, for example, some genetic issues, autoimmune issues, and of course, for most of the times, we don't know the reason behind the low ovarian reserve. Are there prognostic criteria? Well, there have been assessments by teams. The most well-known is the Bologna criteria, the Poseidon criteria more recently. What actually they say is they try to predict who's going to respond not very well, so who's going to be a poor responder. So anyone who has AFC less than 5, that means less than 5 follicles on the baseline scan, and an AMH of less 1.2 is expecting to be a low responder. What it actually means to be a low responder. So most likely we won't get many eggs when we try to stimulate the ovaries. we will have fewer eggs, lower fertilization and implantation rates, higher risk for cancellation rates. So what we can do, what protocols we can do. They have been suggesting, of course, you may more of you be familiar with some terms. Officially, the evidence suggests that the conventional IVF is what is recommended, but it has been suggesting the mild stimulation as well. There are two protocols, the main protocols, the long and the short, but the agonist and the antagonist is the official names, but the use of the antagonist hasn't been proven to be less beneficial than the agonist, so this is why it's recommended as well. It has been suggesting the duostim, and there is a lot of talk about supplements like coenzyme Q10, the androgens like the testosterone and DHEA. Most of them has been studied, and we have a good evidence about them. We're going to discuss later. And of course, there are more invasive treatments. It has been suggested the use of growth hormone, the platelet-rich plasma, and the stem cell therapy, which is experimental so far. Sorry. So, ESRE, the European Society for Human Reproduction and Embryology, has come with guidelines how to treat women with low response to stimulation. And they recommend a few things. Again, the conventional IVF is the one that should be suggested, and the modified natural cycle shouldn't be routinely recommended. Letrozole doesn't add anything to treatment. Clomiphene can be used and considered in combination with gonadotropin, which are the injections that we use of FSH. So growth hormone is not known to be beneficial. Many women come more and more often ask about it, but so far we don't have evidence to support the usage of it. Testosterone, again, is not probably recommended for low responders. And DHEA, again, a supplement that many women use, is not recommended, and that's a strong recommendation. Double stimulation can be used in order to try to retrieve as many follicles or eggs that we can per cycle. Double stimulation, for anyone who doesn't know, is when we stimulate the ovaries, we collect the eggs, and any left follicles that they haven't responded, we try again to stimulate just after the collection. I have added a few cases of our clinic to show how things went for women that they had low ovarian reserve and what we did for them. So a 36-year-old lady had a simple antagonist protocol, responded poorly, had one aspiration, got 2 eggs, 1 embryo out of them. She tried to do another aspiration. She didn't have any embryo. She used her embryo from the first cycle and resulted in a live birth. Another patient, more difficult journey. She started with the agonist protocol. She didn't get any embryos. And then, as she had only 1 egg, it made sense to switch to the modified. So she did clomiphene alongside with FSH. She got 2 eggs and 1 embryo. Same thing with another collection. And in the end, she got another cycle, same protocol, managed to get 4 eggs. She got 3 embryos out of it. She transferred 2 blastocysts, and she had a live birth. Another patient, she had only natural cycles. You can see that, again, the journey was long. 5 aspirations, 4 cancelled cycles. She managed to gather 2 embryos, and she had a frozen embryo transfer and a live birth for that. Many women, I think, you're gonna love that story, a very recent one in our clinic. A 44-year-old, of course, and in that age, AMH is expected to be very low. She didn't respond at all with a diagonist cycle. We say she wasn't able to choose another path, so she wanted to try again. We used testosterone, and we used the agonist protocol. Again, very slow response. Decided to abandon the cycle, but a few weeks later, she told us that she became naturally pregnant. Of course, I have put here many nice outcomes, obviously long journeys for many of those women that resulted in a very good outcome. But we need to remember that some patients may not have that outcome. It may be long, financially, psychological draining as well for many women. So we need to remember that there are always other options. Oocyte donation, embryo donation, adoption, and of course counseling and emotional support, seeking help from other people, or even talking with other people with similar issues may be helpful. But at the end, I would like to put something very optimistic, very helpful, maybe. Impossible is nothing. It's it's how much someone can take, and how much when the journey needs to turn in another way, maybe. And absolutely.
Wonderful. So, do add-ons like embryo glue or PGTA make a difference for women with low ovarian reserve, or is that in any way connected? Is there a connection between them?
I don't think there's a connection straight away to low ovarian reserve, because obviously when we're talking about those, ovarian reserve has more to do how easy it is to create embryos. That's the main issue. It has nothing to do with the plantation or recurrent miscarriages. The main problem is to create embryos, to get to the point that we have embryos. Because of the attrition rates in IVF, that's the tricky thing when we're talking, when we're gathering 1, 2, 3 eggs. If you ask me though, when you have that chance, that low chance to create embryos, then when you have an embryo, it's not a bad idea to use all you can in order to try to improve even the slightest implantation rate.
Okay, brilliant. So that sounds encouraging. That there's a question about quality versus quantity. So, if there's low AMH, would you expect to see low quality as well, or is it more of an even playing field that that there's not necessarily a quality issue if you've low AMH?
There are some people that believe that low MH hides something behind, and the quality is impacted as well, but officially it hasn't been proven. You may have seen from my examples that most of the women were women less than 40 years old, so their embryos are expected to be normal.
Okay.
So I will say I don't have evidence to support that. When we get embryos from young women, again, it might be tricky and difficult to get them, but we are expecting them to be normal. So thus, we are expecting good pregnancy rate when we have a transfer.
Wonderful. And would you expect to see younger women having AMH levels? If you had somebody who was tested, we'll say late teens, early 20s, how unusual is it to see low AMH in that type of age group?
It's not that uncommon. Of course, it's not the average. Okay. It has been studied that long contraception, hormonal contraception that women take for many years can result in lower AMH. It is thought. The belief is that the AMH increases after sometimes 6 months to 1 year after someone stops the hormonal contraception. So the first thing I will ask if they take hormonal contraception. Again, it's not the average. As I had a graph on my presentation, so you can see what it is expected at what age.
Wonderful, wonderful. Thank you. So, would you recommend DHEA for women with low AMH prior to IVF? Are there any other supplements or medications you would recommend?
I'm afraid the evidence is very clear about DHEA that is not beneficial at all. Most studies are looking pregnancy rates and live birth rates, and so far as what we know is that DHEA doesn't improve live birth rates at all.
Okay.
Any other supplements? I'm afraid not so far. As I said, again, testosterone may be beneficial, but it shouldn't be probably not to recommend routinely.
Okay, wonderful. Thank you. Let me see now. Let me see. This is a good one for your clinic because you do have this wonderful egg donation side to the business. When is it too early to consider egg donation?
Oh my, that's a very personal question, and that's very. It has to do with every individual. Some people, young people with not so bad prognosis, they don't want to experience trying with their own eggs at all. Some of them for financial reasons. Some others because they don't want to put themselves into the stress of things may not going as planned. So for others, they may choose even to be their first option. Some others, they like to try a few times before proceeding with egg donation. It's a very personal approach. It has to do with many, many things. We need to remember that also religion is, part of some people's thoughts and feelings. So it may be more difficult for some ethnicities, let's say, or
wonderful
group of people.
Thank you. And what would be your advice to somebody who has gotten a diagnosis of low AMH levels? What should they do next or first?
So first of all, not panic, okay? Low AMH doesn't mean that someone cannot become pregnant naturally. That's one thing. If no other issues and they haven't been trying for long, low AMH alone is not the reason for some fertility. But if they need a treatment at the end, it can be tricky. The journey can be long. Obviously, if we take again away the factor of the finance factor, people need to have patience, I would say.
Wonderful, wonderful. So let me see now. I think I have. Oh yes, how does protein-rich plasma help? And if anybody has any other questions, pop them in.
To be honest, I'm caught off guard on that. PRP is generally considered to be help me with that,
Rejuvenation, yes, yeah.
In general. So it is used in many healthcare, conditions, or even for hair loss. It is generally considered rejuvenator factor.
Yeah.
Well, that's the idea behind it. I cannot be more specific on mechanism, but in general, this is how it's used, and it's supposed to renew the ovarian tissue.
Wonderful. This has been so enlightening. And we're going to wrap up with one last question. What would your top advice be for anybody who is in the situation that they're starting down the route of considering IVF? Is AMH one of those, one of those markers that you're going to say to them, yeah, let's get the bloods done and let's see where we are with AMH? Would that be one of the top things to do when you're starting a fertility journey?
Sorry, did you say age?
AMH. So when you're exactly. So where does it come on the list of getting yourself ready for the IVF journey or figuring out what's happening with your fertility? Is AMH one of the top things you'd be advising that we get tested for?
So as I said, in general, it's the first marker to assess where we are. Okay. But, a couple is advised to proceed with treatment once they've tried for at least 2 years. And for those 2 years, most couples wouldn't have done an AMH.
Mm-hmm. Okay.
AMH is not a low AMH is not a reason not to try naturally, because again, many women may not even know that they have low AMH and may become pregnant just like that. Okay. Yeah. So it's not, if someone came to me and they say, oh, did randomly an AMH, I've never tried, what do I need to do? I will say try naturally first, especially for young women. Keep in mind that you have a low AMH. Come back to me in 6 months to repeat one to see has it dropped, because we don't expect that the AMH will drop just like that. Okay, it can stay stable for a few months, years, and then take it from there, I would say. But it's not, treatment is not the answer straight away.
That's very encouraging to hear. So we have one last question. I had an I will again now try my best, an adenomyomectomy operation in July this year. Do I still stand a chance to try again?
Having just surgery is not, we don't know how the womb looks, how big was the section that you did in your uterus. It's quite tricky to say. Obviously, it's not an ideal diagnosis and not an ideal surgery to do. But not knowing the size, where was it, how the womb recovered, it's too little information. But just because of that, I wouldn't say you don't have a chance. But again, it could be tricky.
Wonderful, wonderful. Thank you so much, Dr. Hatzipanteli, for such a wonderful evening and for answering all of those questions. And I think you're right, AMH, when we hear it, we sometimes feel, gosh, I think you've certainly put minds to ease here, saying, let's not panic. Let's just see how things are. So thank you so much. It's been a pleasure. And for anybody who wants to watch this again, it will be up in ready for viewing, I think, in about 24 hours. But in the meantime, thank you so much for joining us this evening.
It was a pleasure.
Brilliant. And hopefully we will see you again. And it's been a pleasure to host this evening for you. Thank you very much, everybody. Bye-bye. Bye-bye.
Bye.
Thank you.
All the best to everyone.